If we can focus a little bit on this very interesting presentation that we have ahead of us. So I'm very happy to be moderating, facilitating the discussions around local manufacturing. Myself, very quickly, I'm Thomas Sorensen from UNICEF Supply Division in Copenhagen. I'm the chief of the Immunization Technology Center. We have a lot of engagement with industry from an operational, but also a strategic perspective where localization is also in focus. So I'm personally very much looking forward to hear the experiences that we have from the LACRU region with PAHO leading as well. We have two presenters today. So that is Nico Vandaele from Access to Medicine Research Center. And we have Murat Ozturk, is I pronouncing that correct? From PAHO that will be sharing the experiences here from the PAHO region when it comes to local manufacturing and some of the on Murat's perspective on some of the financial barriers, and I think when we come into Nico's presentation on some of the sustainability and equitable development models for those perspectives. So very much looking forward to hear into these. I will hand over, I think, first to Murat and then subsequently to Nico, and then we will be facilitating a Q&A session at the end. Murat?
So good afternoon, colleagues, and thanks for joining us during this session today. This is a very, how to say, popular topic in these days, local vaccine production. Especially with the COVID-19 pandemic, it's all about how we can initiate this in several regions and how we can sustain it. And what I can say in today's discussions, we hope not to repeat what you heard before on how to initiate a local production, but it is about mentioning about the pitfalls and complexity about around issues, and then also the most commonly forgotten things. So, yes, my title of the presentation is about removing financial barriers, but it is mostly about, I will try to mention about the general barriers and pitfalls on how to promote local production in developing countries. By that I mean countries with limited resources. So my key messages, I mean, if I can condense my presentation into one key message, it is about financial sustainability of the local manufacturers is mainly based on reliability, accuracy, and sustainability of the demand by national immunization programs. So if you cannot sell your products, then your manufacturing is not sustainable. And how are we going to ensure reliability, accuracy, and sustainability of the demand by national immunization programs? That's what I want to brainstorm about. Many of our colleagues might not be aware about the PAHO Revolving Fund. Basically, PAHO Revolving Fund, we are functional since 1979. It is established in connection with the EPI programs in Latin America. Currently, we are serving to 41 Latin American countries and territories in both Latin America and Caribbean. 95% of our procurement is financed by domestic resources, meaning that only 5% of our procurement is supported by Gavi or other donors, but 95% is self-financing countries. And our annual procurement volume is around $750 to $1 billion, depending on the year and then COVID response. And most importantly, we have a bridge financing support. We call it like a credit line for around, currently it is close to $200 million at the disposal of our countries to use to procure their vaccines with no interest. And in terms of our principles, it is all about member state solidarity. And then there are other principles about the operations, and then financial sustainability and equity. I don't want to spend too much on this slide, and just want to delve into the discussion. And as we all know, we say expanded program of immunization. Actually, it is expanding program of immunization. It's continually expanding. Like we are, and the immunization programs which were designed by the basic antigens are not now sufficient enough to cover all the new vaccines and then other demanding priorities. And with immunization programs, also PAHO Revolving Fund was extending. So if I can show you our catalog from 2003, you can see there are like 4 basic products, and then overall 18 suppliers in the catalog. 4 basic products. And then the cost of fully immunizing child at that time is around $13. Now, we have 13 products in the schedule, more than 78 different permutations, and then vaccinating per child is more than $100 now. So our model, and then also UNICEF Vaccine Independence Initiative VII model, based on, and then Gavi procurement, pool procurement mechanism. What are the important dynamics of pool procurement mechanism? Like bringing supply, demand together, but you need to do technical support to countries to do accurate demand forecasting, procurement planning, that gives purchasing power also, consolidated demand, and then financial sustainability, like helping countries about budget spaces, etc. So, creation of a pool procurement mechanism for a region is very important, or at the global level, to sustain local manufacturers. Without that, it is very hard for a local manufacturer to reach some kind of a reliability and demand accuracy. At PAHO, we were lucky it happened organically in connection with the development of the immunization programs. And then UNICEF VII is covering some other regions, and then Gavi, as you know, is the biggest pool procurement for Gavi-supported countries. But to replicate the pool procurement efforts in any other region is quite difficult. In terms of, if we brainstorm about the difficulties, harmonization of the procurement schedules of the countries, like synchronization of the times. Some countries, they follow the annual calendar years. Some of them, they might want to procure their vaccines in June, some through the end of year. So if you want to do pool procurement, the forecasting and then procurement cycles should be harmonized. Regulatory harmonization is also very important. Countries should be recognizing WHO PQ, and then in some regions, also in some countries, they are proud of their own mechanism. They don't want to rely on WHO PQ, which will create problems with pool procurement. Pricing policies is another very important dynamic. Because when you talk to members, generally, regardless of the income level, a politician, a minister of health, they cannot afford to pay more than the neighboring country. And the explanation on the income level, etc., will not fly. So you need to come up with a solidarity mechanism in pricing vaccines to your member states. And it is also very important for how you maintain the competition in the region too, because a supplier can engage in predatory pricing just to break down the pool system. They can offer lower price to any country at any point as well. So you need to be protecting the system. In that regard, member state solidarity is another important dimension. And after all, any manufacturer, any model that you have should be agile, self-sustainable, and then with a solid business case. So in terms of the situation and then the demand reliability at the PAHO region, unfortunately, during the pandemic, all the public health gains of the national immunization programs and overall health sector was about to be wiped out. We published some articles with EGLAC to look at the challenges in the health sector, and it doesn't look good at all. Countries are not recovering fast enough, like developed industries. And to be able to, again, the main thesis was, how do we create demand? By revamping and sustaining the routine demand. First of all, national immunization programs, they need to focus on recovering, and then they need to take evidence-based decisions to recover their immunization programs. And they need to respect also the pooled procurement timelines, our PAHO Revolving Fund timelines. And then also they need to keep their accounts with us up to date so that they can continue sustainable procurement. Because if a country, they don't pay back the credit line, we will not be able to continue procurement with them. And finally, their financial sustainability is key of the national immunization programs, but they need to employ evidence-based decision making. And then they need to focus on affordability of the immunization programs. So in order to improve access, I mean, basically, vaccine production is about improving the access, but it is one dimension. You know, national production capacities, enhance demand coordination through joint planning. For example, we have member states like Mexico, United States, they procure their own vaccines. But it's important for us to coordinate and then to possibly to take similar positions in market shaping. The global landscape is very important. And then for PAHO, collaborating with UNICEF and then any other region is very key. And then also stronger regional solidarity and global partnerships. So just to remind the key message, sustaining local production is about sustaining the routine immunization programs and then the demand. And thank you very much.
Thank you, Murat. And over to Nico. Continuation of presentation.
Thank you, Thomas, for introducing. I'm an academic, so you're warned, right? So what are we talking about? Local manufacturing, and I want to start with the thesis. And the thesis is the following, that local manufacturing is necessary, but it is not sufficient. That's, I think, my major thesis. And you already heard that some financial and some market, let's say, deployment is necessary to be successful. The other thing I want to convince you, hopefully, is about modeling. I think if you want to take complex decisions, you need some model to support you. You decide yourself, but a model can support your decisions. That's also another thing I want to share with you. That's also why we use the term ecosystem. It is now used quite widely, but indeed the whole manufacturing is part of an ecosystem, and we have to understand and model that ecosystem to be sure that all the investments, the efforts in local manufacturing are successful. And let's not forget, the ultimate goal is an immunized population, right? So it has to serve that end. So this is then my team, just to say that in order to study this local manufacturing, we have a multidisciplinary team. People are there, engineers for sure, pharmacists, a physician, and on top of that also a philosopher. And I'll tell you why, because in COVID times we suffered a lot to integrate into our model the idea of equity. It is very easily understood, we feel what it is, but how do you put that in numbers? That was very hard to do, and we need a lot of, let's say, thinking and discussion, how to figure that out. And I have to be honest, we're not yet there, so we are still working on that. What is equity and how can we translate that in our models? That's very important. Okay, this is our portfolio. I will, of course, not read that to you. That's something you can do yourself now while listening. But I just want to see that a lot of things we do has to do with vaccination and immunization, right? So a routine immunization, but also if you go to these neglected tropical diseases, and of course, as you also see, HIV is maybe not directly the vaccine, because that has been pushed back a bit in its development, as you know. But next to that, we also work on antivirals, and art is, of course, a very important element there. Why do I mention this? Because if vaccine modeling is already quite difficult, including the manufacturing for HIV, on top of all the other stuff, you have the big stigma and a bunch of other things. So that's why I definitely want to mention this, because that's even more complex. Then pathogen X, that was before COVID, when we collaborated with CEPI on 5, let's say, neglected tropical diseases. And I still remember somewhere in February, CEPI called and said, look, you from university with your team, can you drop the pencils and can you work on COVID, please? Because we will need models be ready as soon as the vaccines are getting out of their R&D stage. So in the beginning, there was no vaccine. There were plans and there were attempts, and we were already building the models, of course, with fictitious data. And as soon as the data came in from the manufacturers, we were able, let's say, to develop the models further. And then, yeah, as everybody here in the room, I think COVID-19 took us a lot of weekends, a lot of nights, but we were able to do a lot of modeling. And for your information, we did quite some work under the umbrella of CEPI for COVAX. So the 4 manufacturers which were engaged by CEPI, we did the modeling for that. And then, of course, we hope that if your house is on fire and everybody is carrying buckets of water, then it's not bad that somebody steps aside and thinks, maybe next time, if the house is on fire, should we still carry buckets of water? Is there another way to extinguish the fire? And then pandemic preparedness came along, and we also tried to use the models we developed in COVID for pandemic preparedness, and that's what we currently do now. And of course, as at the outskirts of the whole, let's say, inequity in COVID times, the local manufacturing came up. So currently, for your information, we work for the African Union, African CDC, PAVM. We work for the European Union, and we hopefully also could contribute with our models to the Latin, Southern American, and PAHO environment. So the last column here is living models, because everything we do is part of a dynamic world. And the diseases are, let's say, they are dynamic. People's behavior is dynamic. Politics is dynamic. So our models have to be continuously adapted. Not just the data, the models have to be adapted. And that's an endeavor which also is not that easy, because in immunization, you know it better than me, we do not talk about 5 years. We talk about decades of work. So we have to be sure that the models can grow, can evolve, and can adapt. There are some references here at the bottom for some European projects. You can figure that out. If you Google, you definitely will find them. This is our approach, for your information. So if I try to convince you that manufacturing is part of a larger ecosystem, you see it a bit at the left. I will come to a larger picture soon. Human behavior is not far away, because even manufacturing could be quite technical, the bioprocesses, but at so many points people decide. We already heard Murat on, let's say, financing decisions and also vaccination schemes and so on. It's all about humans and about things, so we have to include that in the model. And not to forget, of course, the point of administration. And so the agent-based idea, the human behavior there, the uptake, the hesitancy, the complacency, the convenience, everything you know about that is also part of our models. On the right-hand side is a 5-step approach. I will also, given to the time limits, go into the details. It's written up in the paper you see below, and that's in fact basically that you cannot start modeling as first thing. You have to talk to all the stakeholders to understand. And even, for instance, in COVID times, we discussed a lot with anti-vaxxers, because we want to know, okay, what's up? Why do you say this? We want to understand, and also a very tough element, I can share that with you. It's a bit aside manufacturing, but it's part of the whole thing, is that hesitancy among healthcare workers themselves, because they give advice. They are a multiplicator effect for the good, but also for the hesitancy. And that's something I can share your experiences offline, but that was a very tough job, to be honest. Okay, but we all need that stakeholder information to start the modeling. And then when the modeling is done, we have, let's say, a base model. Then we go back to the stakeholders, or at least to some key stakeholders, to make scenarios. Yeah, I talked about 20, 30, 40 years ahead. And that means that we need scenarios. We cannot build decisions today. We need to see, okay, what is the best plan so far? And then do we have a plan B, C, D, and so on when things go by? And can we adapt our approach? You see here also on the right-hand side a picture. It's not of vaccination. It's about HIV. And indeed, again, a system has a goal, and the goal is immunization, or how can I protect your child from getting HIV? And that's what we try to do. Okay, so here's some, let's say, triggers for our work. Probably you also know the 100 days ambition of CEPI, and that's about can we get ready with a vaccine or a batch of vaccines within 100 days after the declaration of a pandemic epidemic? Well, it is very easy said. It is very easy to put into a contract, but will it materialize? And that's a concern of everybody. It's CEPI's concern, it's the government concern, it's the manufacturer concern, because everybody wants to do the job within 100 days, okay? So what can we do with the model? We can offer to all these stakeholders a model so that they can check whether it's feasible to, let's say, talk about 100 days. And if not, maybe we can use the model to find the bottlenecks. Where are the root causes that you cannot meet the 100 days? Is it capacity? Is it knowledge? Is it your starting condition? Whatever it is. So that's in fact why we collaborate quite a bit with CEPI on several manufacturers in Europe and also now in Southern Africa. So coming to PAHO. PAHO is our collaborator here in these. My counterparts from PAHO are not here at this meeting, but we collaborate quite a bit on that. And that was very important because we do the manufacturing modeling, and that necessary condition, okay, we need manufacturing. The sufficiency condition comes from PAHO working with Chai on, let's say, what is a viable market, right? And two things about that. It's not on my slides because I wanted to do it orally with you. So it's fine. We reversed, in fact, the priority we tried to reverse the priority first induced by the African Union. They said, look, we need vaccine manufacturers for pandemic, epidemic, outbreak, and then routine. That was the first. I mean, I understand that in a pandemic, that's the thing, you're lying awake at night. But we tried to convince them on the longer term, it's better to turn that upside down, work on the routine, work on the outbreak, and then on the epidemic and the pandemic, right? To be sustainable, as already discussed, on the longer term, so that the manufacturing can grow, that governments can get trust in the manufacturing, and that it can last for 20, 30, 40 years, okay? So that was one realization of that option. The second one is that the first list on the 2040 ambition of, and I think it's there, on the 2040 ambition was 22 pathogens. You cannot do that all at once. And so we also tried, together with Chai and PAHO, figure out, okay, the 22, we turned to 18, and then finally we now ended up with 5, of which, together with a bunch of stakeholders, we believe that these 5 vaccines are viable on the African soil. And now these models are more and more elaborated. Just for your information, it's also not on my slides, but for the 22 pathogens, we did the analysis. We modeled every of these 22 pathogens. What is the manufacturing facility you need to have 60% of the vaccines produced on African soil in 2040? I can tell you, for all these 22 pathogens, we need 12,000 skilled people for all these facilities. And I talk about direct labor, not about all the managerial and all the other stuff. So that's really a challenge. So we also have to take that into account. And so all these sufficiency conditions, right, we need to take into account. And not to speak about the labs and the regulatory agencies and so on. So this is then indeed what I just discussed, right? And now I want to share some work also we do with Germany, because another idea I want to launch is the idea of frontrunners. Regional manufacturing is fine, but each region is composed of many different nations. And of course, you cannot do it all in all nations. So what shall you do first? And I think we've seen it in Europe. Europe is slower than an individual country. Also in Africa, I think Africa is slower than an individual country. So if there's a country which has some potential, some, let's say, good fertile ground, why not, let's say, give that country a chance to make a pilot, to make a front-runner role so that the others can benefit from the learnings, right? That also took a bit of time because that's not the message, of course, a union wants to hear, right? It's more like do it together. And therefore, a front-runner should, of course, agree with the global umbrella union that everything you learn, the good and the bad, is transferred to that union. So that's why we also work for the. And here you see ZEPI is the body in Germany who is doing this pandemic preparedness, and they make contracts with manufacturers for this 100 days ambition I just talked about. And there you see already the systems approach. And that's in fact what I want to come to here in my session, is that manufacturing, but everything surrounding manufacturing, all of that has to fit nicely together. And if it's one of these things is missing, then the thing won't work. Okay, so you see here what I'm trying to tell. Okay, so let's now go back to our point of administration. It has been tackled a lot here in this couple of days. And indeed, we usually model 3 flows. right? It's a very physical way of reasoning. You need a vaccine, you need a healthcare worker, and the kid or the person to be vaccinated has to show up. There may be some other things in the material supply with the syringe and so on, but okay, let's call this as one material flow you need. Let's just do the calculation. If there's a probability of 95% of each flow being successful, 95 is not bad, right? 95% of the people showing up, 95% availability of the vaccine, and 95% of the staff being there and not sick and so on. Well, multiply these numbers and you end up with 70. So you see immediately that these flow combinations are very important to model and see how we can increase, of course, the immunization and the vaccination and the of course, the reverse sequence, as I'm telling you now. So these flows are the heart of our system model, and then you see it like this. I cannot go into that because it takes a while to check all these causalities. And these are causalities, right? What is influencing what? In the middle, you see the vaccination point, but you see there also population well-being. You see immunization plans. These are the government national immunization plans and so on. So all of that fits together. And if one of these causalities is not going well, then you see that the point of vaccination will suffer. You also see the right-hand side. That's a bit also when you see outbreaks, right? So we studied, for instance, 2 villages in Rwanda where measles were, let's say, popping up again. There was an outbreak, and the question was, come on, we have good supply chains. Things are there are no stockouts. Why is these measles popping up? And yeah, so that means that we need to understand the whole system. And it was not a problem of the supply chain. It was a part of communication and understanding of the mothers that, for instance, MR2 was not considered as something needed. MR1, oh, I'm vaccinated. I mean, my kid is vaccinated. That was enough. That was one of the things we found out. And that's, of course, also has to be part of the model. Otherwise, we do not do it correctly. Okay, so this is a bigger picture of the same thing, and you can think about indeed a kind of a planned, let's say, a part of it and a more emergency immunization. And of course, it's kind of a balance, right? And in terms of outbreaks, it goes more to the right. In terms of, let's say, peace, it goes more to the left. But both have to be taken into account, and you cannot neglect one of them. For instance, one of the things you can nicely model here, and that we experienced very highly in COVID times, was the fact that so much staff was deployed for COVID that, of course, the regular immunization suffered a lot. So these are some models. Sorry for that. So we have, in fact, 2 big steps, and we model first qualitatively. We heard a lot also here in these days about stakeholder analysis, participatory work, and so on, stakeholder analysis. Well, that's what we do, and we try to mimic that in system maps. That's also a technique many of you are using. And once you have that, and in a particular structured way, you can turn that into a mathematical model. This one is particularly interesting because these curves are what you could call throughput curves of a manufacturing network. Of course, I cannot disclose which one it is, but you see the red one was in COVID times. These are the doses coming out of this network. A network can be one supplier, can be a couple of combinations, that doesn't matter, but the network is spitting out number of doses per month, for instance. That's the throughput. You see in the beginning it is 0 because there was nothing coming out, and at a certain moment the first doses, the first batches were coming out of the system. And the red one was, in fact, why it is a little bit curved, is because the whole biomanufacturing is very stochastic. The yield is not fixed, the batches can be discarded and scrapped and so on and so on, okay? What is then a nice example here? So the red curve is useful for the manufacturer, that manufacturer can share with the government what they can promise, and the government knows, okay, these are the upcoming batches, I can plan my vaccination campaign accordingly. The blue one is related to a plant of that network which was contaminated itself. So the people were infected by COVID, and I think 30% of the people were have to stay at home, and the plant was closed. And then you immediately see the impact. That's a scenario. Okay, of course, it's a bit shorter term because it was COVID, but you can do that for every manufacturing network as you wish. So that was the stockpiling here at the bottom for some neglected tropical disease. I'm almost there, right? This one at the bottom here, hard to read for you, but this was what we did in these 2 villages in Rwanda to figure out why is there a measles outbreak, given that manufacturing and supply chain is really doing well. And this is then also more detailed about that. Okay. This concludes my expose. It was maybe a bit running, but I'm a runner myself, so I hope it was possible to follow. And thank you for your attention, and definitely ready for some additional questions or remarks. Thank you.
So thank you very much, Nico. And yes, maybe, but also complex stuff that you are summarizing there. And it's very also good to see more an academic view on some of the processes that we, collectively have gone through as part of the pandemic response. And it's also great to see how that can be used into some modeling that can help us in future pandemic situations there. And I think that came out quite clearly in the presentation. Similarly, I would also say, Murat, coming from UNICEF, can totally relate to your key messages on the importance of ensuring sustainable demand, sustainable financing as preconditions for encouragement of production, whether it's within the established industry or within manufacturers that you want to grow locally one way or the other. I have a few questions related to this, but before I start to moderate the question, I'm just looking into the room to see if there's any questions from the floor. And I can see there is a lively hand raised here. So please.
Thank you. I'm Ulla from UNICEF. So Nico, excellent presentation. I'm really excited. So can you tell us what those 5 antigens are that you said were the most beneficial to be produced in African soil? I think you said that. I would love to know what they are. Anyway, and then also how long do you estimate that it'll actually take to build local capacity in a front-runner country, for instance, in the African region? And also, we haven't talked about this for a while, but I remember in my younger days, we were often, when there were less manufacturers, I guess, and prices were considered high, sometimes people were working on trying to actually estimate how much it costs to, prices are not based on cost, right? But they are based on profit maximization. But are you using your model to try and estimate how much it actually costs to develop vaccines? That would be really useful. Thanks.
Thanks, Ulla. Okay, may I suggest just to take 2 questions and then answering, and then a couple of more rounds.
I'm from Turkey, Ministry of Health. My name is Tarkan Yamanoğlu. I would like to share my idea with you. If there will be a shortage or pandemic breakouts, there will be need you and all of us need to know the capacity of vaccine production, manufacturers' capacity. Is there any database that centralized database can know how many manufacturers there are in the world and what are their capacity and what are their technology? Is there any such a knowledge or data? Because most of the vaccines is not included in WHO pre-qualified list. For example, someone FDA or EMA may change, and also Asian manufacturers there are.
So
it will be helpful for next pandemic, I think. Thank you.
Thank you. Thanks a lot for these 2. Nico, you want to start?
So yeah, if you talk about Africa, there's definitely some regions which already have something in place. So why should you start from greenfield if there's something already proven? Because proven experience is important, for instance, for trust, for this governmental trust you were talking about. Another thing is you may not forget that if you have greenfield especially, but also if you do tech transfer, that you have a learning curve, and in the beginning you're more expensive than the others. No escape. So someone has to close the gap somewhere for a little bit of time. There's no other way. You cannot compete with someone who's already 30 years in business and knows all the tricks and the risks. So that's something, it has to be nurtured in the beginning, but of course, again, not forever. So it also has to graduate, like we know for the financials from Gavi, for instance. Also, the manufacturing has to graduate at a certain moment and be competitive. Also important is that it will not be divided among all the countries, because that's impossible. So you have some regions in Africa. Southern Africa is one. You have the region West Africa, Senegal. You have Northern Africa, but that's usually a bit split up, to be honest. And what is, of course, also very important is the difference between drug product and drug substances. So that's not, not that hard to do the drug product, but the drug substance is much more complicated. And then, of course, you also need to take care that if you do that, you have also to look at your sourcing. It's not enough to do the manufacturing, but for instance, issues like, do you have the eggs yourself? Do you have all the material yourself? we were very hard, let's say, struck in COVID times that, for instance, even stoppers, even very simple things were not available. The glass at a certain moment was a shortage. All these kind of things have to be taken into account if you kick off local manufacturing or scale it up, right? So that's usually what we do now. So I refer to the, let's say, the 5 vaccines we think, together with China and PAHO, that are viable, that they are also possible to have all the sourcing locally. But again, also from the market perspective, there's not the critical volumes you produce will always be larger than a single country's needs. So you need to collaborate to have that, let's say, to absorb the production of these. I will not also refer to the examples who tried and were not successful. You all know the names. So I think we together cannot afford another failure. So if we do something, it has to be good from the very beginning.
Thank you. And 2 more questions.
Okay, thank you very much, Professor Nick. I think a very interesting and insightful presentation. So 2 questions. Can you expand more on your findings in Rwanda, why we have recurrent measles outbreak? I think that's very important. We are beginning to see a lot of resurgence of measles across Africa, and if there is a functional API system with trained personnel and also good supply chain, and then we begin to see outbreaks in the setting, then it raises a lot of questions on what we can find in countries with very fragile and fragmented supply chain systems. So I think it will be helpful, particularly for me, but I can follow up on that with you. And then the second question is, given your relationship with the African Union, is it really, can it be possible for you to actually convince them to rethink about their concept or approach to local manufacturing? Because they got a lot of money to manufacture vaccines, but this morning we actually saw that they are like the highest importers of pre-qualified equipment, but they don't have facilities to manufacture cold chain equipment, not even things like syringes and also safety boxes. Why can't they start with things that are less complicated before moving up to the things like biomanufacturing, which is very complicated, which, as you said, require about 63,000. Is it like direct labor, not to talk of managerial jobs? Why can't they start with the simple things?
Thank you. 2 very important things. So the explanation of the 2 villages in Rwanda on the measles outbreaks. One was that mothers thought, as a community or as a group, that 1 shot was enough, and they didn't show up in a bunch of times for the second MR2 dose. Okay, that's a communication issue. That turns out to be, or in our case, in that village, the reason that the measles broke out. The other village where it happened was a peri-urban situation. So that element didn't play. The people were well informed, but there was a lot of migration in and out of that peri-urban area, and that also contains some risk. So for that setting, that was let's say, the root cause, we call it in systems thinking. So you try to dig, and then you find something at the bottom which impacts all the other things at the other levels. Yeah, so these were the 2 things. But those villages, of course, it's very localized, which it could be other villages with other reasons, of course, for an outbreak. But in those 2 villages, these were the reasons, main reasons, root causes. To this African Union and producing more, what you could call simpler, let's say, products. Yeah, that could be a way out. But indeed, if you want to be reliant on vaccines, then the vaccines are the things to produce. But what is important, we may not forget, if we indeed need all this, let's say, a bill of material for making a vaccine, so all the materials you need, that's quite a long list. And also that list has now been reduced to 20 things you need, which are critical or were critical in COVID times to produce it. And these are also looked into, that you can produce them locally or at least very closely to the main facility. Yeah, that's and this contains the things you mentioned, and that could probably also facilities which can produce not only for the vaccine business but also for other healthcare products like syringes or yeah, all kinds of things. Yeah.
And yeah, so thanks for that. And if I can just supplement a little bit, and I fully agree with the questions being raised there on maybe trying on some of the more simpler thing as well. I think the whole premise for the analysis is that we have an emergency, and the emergency also sparks action. You have a lot of actors moving in the same direction, which are very, I mean, in a bad situation as an emergency, it's a good thing in terms of getting activities done, right? Including also maybe solving some of the more difficult areas. But I think in a more also normal day-to-day operation, and when we talk local production, it also has the sustainability dimension to it. It also have the local job creation. It does have a lot of these elements associated to it. And we all know that vaccine production is difficult, right? And it's not to say that we should not. We should definitely try to pursue. And I think African Union indeed have some good spark in this direction for the moment. But in the meantime, areas, when we look into the immunization area of, for instance, 80 syringes, is a critical, I mean, commodity associated with vaccine supply chain. And I think here we have some good examples. We have Revital in Kenya for the moment that is being pre-qualified. Actually, we also have in Rwanda, I think you mentioned Rwanda, also local production in the mode, therefore pre-qualification. So quite similarly, one could be looking into the cold chain area of maybe not fridges in next year or the following, but definitely on cold boxes, vaccine carriers, that type of production, and get that mobilized on the continent. I think it would be much easier also in some of the modeling. And this might be where it's, if one could challenge also from an academic point of view, the notion of the speed into the model. I mean, what do you think about what is catalyzing all the actions? So an emergency is definitely catalyzing, but if the emergency is not there, then what is it supposed to be catalyzing is critical question. These are just observations for me as a moderator. But Hilo, I think there was also a question from the floor. I think, yes.
Yeah, okay. Just maybe it's good presentation. Just one quick question, I think for Murat also. When you look this financial sustainability, PAHO procurement, this problem are there for the past decade. Because, 5 years ago, always PAHO, they say this, all this. What is the mechanism way forward that will address this once for all? Because every year this issue are there. Is there an upfront kind of financial coming in so that this procurement model always is sustainable in work or not? And what do you learn also from UNICEF global procurement so that it address? The other one, best value for money, the least price and cost, it says it's also confused because sometimes supplier competition, and then they see also where are the country status in terms of economic status, those who are low-income country, middle, and so on. Those was another challenge which are coming for competing kind of price base to get. So how do you see this one? On the other side, which my question comes is, when you see, it's like the pandemic context. It means we are talking after R&D, research and development, after all PQS approval that it comes as a patent, so somebody will have an agreement to produce it locally in Africa context, because then who will cover the cost of R&D, how much spend on that? That's one. The second one, in terms of now when you see unit cost of some of typical routine vaccine, the price has gone so much down, yeah? For example, in Africa, even on average, if we say, let's say Africa has 1 billion, and then if annual births we estimate, let's say 3-4%. If you multiply that, and let's say for BCG, MR, measles, it doesn't make cost at all, even covering the whole Africa in one giving. And then the other dimension will be also, if all Africa is that way, then what will be the global manufacturer make value for money so that they do also this production is another issue in terms of quality and all other aspects. How that modeling is looking these aspects, apart from the emergency response to routine and so on.
So thanks for that question. I think Murat was posed for you, and then Nico subsequently.
Thank you, Hilo, for the great questions. Firstly, the situation of self-financing countries is a chronic one. Maybe more than 15 years ago. When you look at the HPV, PCV rotavirus introduction, except PAHO region, in any other regions, middle-income countries suffering. And that suffering is not only for, we have a session in the afternoon on the fiscal issues, but PAHO countries, they are sacrificing at the expense of other issues. The cold chain equipment in the region much worse than Africa. They cannot invest cold chain equipment. The new vaccines are so expensive. And when you look at UNICEF VII, we have been suffering. You know, I was part of VII for a long time, for middle-income countries. So the problem on the affordability and vaccine prices for middle income is chronic. And for me, there is no upper middle income, lower middle income, lower income. We have bankrupt ministries of health and then rich ministries of health. And almost all the ministry of health that I work with is bankrupt. And it is no difference if it is Brazil or if it is Botswana. So basically, middle-income countries cannot afford new vaccines. And then this puts the demand reliability in trouble because they're like, you know, they cannot, and we have a credit line. So we can keep track of countries' payment performance like a bank. So the situation is not very optimistic in that regard at all. In terms of R&D costs, suppliers are not revealing their R&D costs openly. So most of the vaccines developed, there was a survey, many suppliers, they get also government supports. And such support are not integrated. So we don't know if we are really reimbursing the R&D cost or marketing and advertisement cost of the supplier. Yes, maybe Nico.
So as we are running out of time, Nico, maybe just very quickly to respond to the last question.
I will try to be very quickly. So if you recall my systems map, right, on the left-hand side, you have R&D. I think that's a crucial element. Why? Because I think if you go to local manufacturing, it has to be locally adapted. I mean, the success, for instance, and I will now name one, IPD in Dakar, right? Why are they successful? Because they always adapted what they did to the local situation, right? And that is a very strong sustainability element. Of course, if you have an R&D hub with spin-offs, with universities, research labs, then it means that you also build the HR capacity. People learn in these institutions. And then when you have this, you have pharmacists, you have physicians, and I mean, the whole thing after a while can, I think, pay off on that. So I think if you look at the places in the world where these things really go well, is because they have a kind of a boiling pot of all these things together. And it's usually around research. So there it all starts. And research has been found to be adaptive. The other thing on your economics is that I believe in the division of labor, because you're a union of 50-something states. The European Union is also something like 30 states, let's say. Well, you cannot do it all individually. So you do manufacturing, you do the regulatory, you do this, you do that. I think that's also a good way to collaborate. So you need each other to get further. That's, I think, one of the principles, which is because it's, I think, economically infeasible for every country, of course, to do it on its own. If you look at some countries, again, I will not names, but sometimes with one pallet you can vaccinate the whole country, way to speak. I mean, that's possible. So why could that be viable in terms of production?
So thank you for that. Thank you, Murat. Thank you, Nico. Excellent presentation and also good attention from the audience. Good questions. So thank you very much, everybody.